specializing in cardiovascular disease with a focus in advanced heart failure. She earned her Doctor of Medicine at University of Nairobi in Nairobi, Kenya, and completed an internal medicine residency at East Carolina University in Greenville, North Carolina. Dr. Njoroge completed fellowship training in cardiovascular disease at Marshall University in Huntington, West Virginia, and also completed subspecialty training in advanced heart failure and cardiac transplantation at Case Western Reserve University in Cleveland, and also University of Kentucky in Lexington, Kentucky. She's board certified in cardiology and echocardiography and nuclear cardiology. Dr. Njoroge has disclosed that she has no relevant financial relationships with any ineligible companies, and she will be presenting today on optimizing heart failure care. So please join me in giving her a warm welcome.
Thank you, Dr. Robinson, for that very kind introduction, and welcome everybody to today's talk. I'm going to be talking about optimizing heart failure care, identifying our advanced heart failure patients, and what role the mechanical circulatory support plays, which is temporary versus durable. And the durable is what we know as our LVAD therapy. And so I have no disclosures. These are our objectives for today. We're going to discuss the definition of what advanced heart failure is, talk about the temporary and the durable assist devices, and recognize some of the complications with the durable VADs. So why are we talking about this? Why is this important today? So advanced heart failure has been compared to advanced cancer. It just doesn't get the gravity that it deserves. And part of it is because we do not recognize it. It's more insidious. And just culturally, cancer, the big C word, is more of a scarier diagnosis than advanced is, but they're actually comparable. And so we need to be proactive about identifying these patients. They actually walk among us, and they struggle for years before crashing and burning as we know it. And we can cut this cycle short and identify them and refer them before they get to the point of no return, before they get to the point where it's just palliative care. Think about it as diagnosing stage 1 versus stage 2 heart failure compared to metastatic disease. I mean cancer compared to metastatic disease. And so we all play a vital role in our heart failure patients. We get a lot of fatigue when we get these patients in the hospital. Frequent flyers, we call them, they come in through the door. But every time we see these patients coming in with recurrent heart failure, we know their time is limited. And that's why we have to be more proactive. And whenever I give this talk, I hear later on that people also identify it in their family members, in people that they come into contact day to day. And you can actually save lives by early detection, recognition, and sending them to specialists and higher centers for them to get worked up and treated sooner. It is a very serious disease. About 6.2 million people are currently living with heart failure. About 10% of these patients are in advanced heart failure. They're walking and talking. We just don't know it. And hopefully after this talk, we will. And there's a median survival of less than 2.4 years in an advanced heart failure patient who's been hospitalized. So think of that when you see a person with an EF of 10%, and this is their third admission. They might not be around in the next 3 years. And this is the number of deaths that has been identified or attributed to heart failure deaths every year in the US. And it's on the rise. It's not getting any better. And in the recent years, there's been a 24% increase in heart failure deaths. As I said, every time you see these patients, their first hospitalization, every time you see them, their survival goes down. By the time you see them the fourth time, it's really something to think about. What do they need? Do they need a heart pump? Do they need heart transplant? What are we doing with their medications? Do we need to be more savvy about titrating the doses and trying the best we can, and not just getting tired or fatigued and thinking, this is arthritis or something that's just chronic. No, every time you see these patients, we have to think. And so this goes into our NYHA classification. So we have, my pointer works here, but NYHA classes also correspond to the stages. So stage A, heart failure, are patients who are at risk. These are probably people we all come into contact with. These are probably people that we are ourselves. Patients who have significant family history of heart failure, hypertensives, diabetics, people who are not progressing with their standard treatments. And then we move into stage B. Stage B is where you actually have structural disease, but you don't have the manifestations of heart failure. Stage C is when you actually have structural disease and you have symptoms. And people will be teetering in stage C for weeks, months, years before they get to the stage D. So the stage D is point of no return, where you have refractory symptoms and you require special intervention. And patients NYHA classes. So class 1, you have dyspnea with very extreme exertion, class 2 with moderate exertion, class 3 with mild exertion, and class 4 is you just dyspneic at rest. People can go in between these classes, but the stages progress. So you go from A to B to C to D. And once you're a D, you're never coming back to A. So we need to proactively identify our patients. So once they're initially diagnosed, there's this initial dip before we actually put them on the GDMT, we diurese them, we optimize them. And if their heart function does not recover, we are at the point of where we are at risk of sudden death. If their EFs are less than 35%, that's when we start thinking of defibrillators, putting life vests on them. Any arrhythmias, how do we treat them? And then we go through the period of decompensation. So this is probably where we see a lot of our patients. My pointer's not working today. And then they progress to end-stage heart failure. So we need to start our patient education the first time we identify them, discuss treatments and therapy options, and just lay out the land, how this is going to be. This is not a one and done. This is going to be a long-term relationship. And then when we transition to advanced heart failure is our GDMT failing? Do we need to send you now to somebody else? So I lean a lot on the 2022 guidelines. I bring this slide up just to show us the level of recommendation. Green is always good. It's a class 1 indication. There's class 2A and class 2B. So class 1 has strong recommendations, usually based on clinical trials. Then there's 2A is a moderate indication. 2B is usually a weak indication. And class 3, whenever you see red is bad, don't do it. And there are things that we used to do in the past that we don't do anymore. And so whenever we see this color schemes, you tend to recognize what we're talking about. So we talked about the stage A patients and the pre-heart failure patients. Stage C are the symptomatic heart failure patients, and the stage D are advanced. So stage C is where we need to be more proactive about, and we need to start thinking about the trajectory. Is it new? Do we have complete resolution of symptoms? Is it persisting or is it worsening? Are we getting back to some form of baseline, or are we just going to the crashing and burning stage? So assessment is what we all know: clinical history, physical exam, labs, and what's specific to heart failure is natriuretic peptides. So we have our NT-proBNP or our BNP. What we have here at Firelands is BNP. Transthoracic echo, additional testing if necessary, and that could include cardiac MRI, PET scans. We can do MUGA scans if we're not able to get good ejection fractions. And so that's how we confirm our diagnosis. We need to identify the cause. We need to see any precipitating factors. Is this person an alcoholic? Is their thyroid function out of whack? Are we initiating treatment? What's preventing us from initiating treatment? What's their kidney function? What's their blood pressure? What are the social factors that prevent them? Do they have mental issues that they're not able to follow up? Should we take care of those first in order to ensure that they're compliant? Let's not just deem this person non-adherent or non-compliant. There could be so many things going on. And then the most important thing is serial assessment, because we need to reclassify classify and reclassify these patients. So we don't get one echo 6 years ago and say their EF was 20 and we forget about it. No. So then there comes the definition of what is HFrEF, what is heart failure with mid-range EF, and what is HFpEF. So anything less than 40% is HFrEF, and anything between 41 and 49% is mid-range. It was important to classify this mid-range because the standard therapies don't apply to these patients because they could be either getting better or getting worse. And reclassifying over and over is important. And then there's HFpEF, EFs greater than 50%. And then serial reclassification, you come into these new terminologies like heart failure with improved ejection fraction, HFpEF. So we need to figure out where our patients are on any given time. And as I said, there are limited modalities. Say, for example, you find this patient whose EF is 45% and it always stays there. It's always tailor-made to what other comorbidities they have. So are they diabetics? Would they benefit from an SGLT2? Is their blood pressure through the roof? Spiro and Entresto could come in handy. And then keep reclassifying these patients. Always assess the risk factors. It's very easy to keep seeing patients with blood pressures of 140s and ignoring it. That's not a normal blood pressure. We got to correct it because these are the stage A's who then will tend to progress. Obesity is a big thing. And now with GLP-1s, we're seeing a lot of benefit in our heart failure population once they start, their BMI start coming down from the 50s to the 40s to the 30s. So we need to also think about obesity, especially when it comes to HFpEF. Ischemic heart disease, if they have symptoms, refer them. Some other non-ischemic causes that we don't think about is chemotherapy induced. So you have your adriamycin-based chemotherapy regimens. Familial heart disease, make sure you're getting your 3-tier history. Make sure you ask about grandma, aunts, uncles, cousins, nephews, nieces. It's always good to go back. History is always so important. Any arrhythmias, do they have uncontrolled AFib? Do they have PVCs, 30% burden? Those can cause heart failure, and they're very easily reversed. If you send resistant AFib or persistent AFib patients for ablation, this can actually reverse and can work better than just GDMT. Peripartum cardiomyopathy, Takotsubo cardiomyopathy is an entity that we're seeing more commonly, and substance abuse. So class 1 recommendations are very easy. We do this all the time when it comes to history and physical exam and lab and ECG testing. What we do is usually class 1. So, but the gist of what we are here for today is identifying that advanced heart failure patient. So a patient who's ever needed dobutamine, ever needed milrinone in the hospital, we have to start thinking, oh, this person might have an LVAD or a heart transplant in their future. Patients who have persistently elevated natriuretic peptides, you come in, their BNPs are always in the 500s, they're dry, there's nothing else you can do for them. And keep in mind, so this mnemonic, it's I need help, and I'm going down through them, and it's any one of these should trigger. You should be thinking about what else can I do for this person? And organ dysfunction. So they're becoming CKD4, CKD5. You're starting to call nephrology on board. Their EF is 20, never improved. You need to start thinking, hey, 2 organs are down now. This person is not doing well. EF is persistently low. You've gotten their ICD. They have a CRTD, but it's still low. Now the device is starting to shock them. That's a bad sign. We've talked about hospitalizations. They're always wet. We can never get them dry. Every time you try to up-titrate their diuretic, their creatinine goes up. Bad sign. And then now you start weaning down their GDMT. Not good. This means they're intolerant and that they need more. So they need help. So always think about, I need help. So I've shared the slides. We can go back to this, and I'll talk about it a little later on too. And so, when you have that Entresto patient who was on a high dose and now they can't even tolerate half of the lowest dose, it's time to think about it. So managing, again, this is the basic things we do, and I'm bringing this up. We know about it, but it's basically highlighting what's guideline based and what's class 1 indication. So we all know this. So for primary prevention, people who are at risk, we are controlling all the risk factors. For stage B, we are preventing the syndrome, the CHF. So We're making sure that they're on their ARNI, the beta blockers, they're getting ICDs. If it's familial, they're getting genetic testing, and that's a 2A indication. So question, are we sending our patients for genetic testing if aunt, grandma, and son have CHF? And Cleveland Clinic, University Hospitals, they have good geneticists who are doing that. Treatment stages C and D, so we know our step one is to establish the diagnosis, do the GDMT, and then reassess. And then the step two is titrating to target doses of medication. So starting them and getting them on the 4 pillars is great, but every time we meet these patients is an opportunity to up titrate the meds. So Entresto, 2426, 4951, 97103. SGLT2 is great because it's just one dose. Spironolactone, we can start slow, 12 and a half, and then we go to 25. Toprol highest dose is 200 milligrams. So think of all your patients that you have with low ejection fractions, and are we doing the best by them by keeping them on low doses? Probably not. Step three, then we think about other things. If they have more than 1 year survival, you're putting defibrillators in. If they're African American, are you adding biodiol or hydralazine nitrates in addition to the 4 pillars? Are we sending them for CRTDs? And then after that is when we're like, okay, this patient probably needs more help. So step 6, which is the final, which is the patients that we're very interested in, you have class 1 indications for devices, durable MCS, which are the VADs, class 1 indication to send them to transplant, and a class 1 indication to get your palliative care on board. Talk to Dr. Robinson and see if does this patient really want to go to Cleveland, move their life there in order to establish a new normal where they can be worked up and get a new heart or a new pump. Other additional therapies that I won't really spend much time on, just to make sure that we remember the level of evidence. Ivabradine, if your heart rate is too high, something that you can add. Digoxin is there as a 2B that we know of very well. Then we have our potassium binders. When you have a patient on Entresto and spironolactone and they're still hyperkalemic, that's when we have our Lokelma and our Veltassa drugs. These are newer drugs to help keep this potassium down. That way they can stay on their GDMT. Remember, midodrine is not on there. It is not indicated. It's something that we put on to help our blood pressure look better, but there's no level of evidence for that. Other devices that we can put, MitraClip can reduce symptomatic mitral regurgitation only after you've optimized the GDMT. And this, it's highlighted here again that you have to, it's a class 1 indication to optimize your GDMT before referring them for a MitraClip. Even if you send them to a structural heart disease person, they did a trials, and the co-op trial showed evidence that patients who are on good GDMT did much better after a MitraClip. And then class 2B indication is the CardioMEMS, which prevents heart failure hospitalization. So it's indicated, but it has a weak recommendation. So referring these patients, why is it important? 53% survival at 2 years, 47% survival at 1 year in patients with advanced heart failure. Remember the I need help mnemonic. It is a class 1 indication for timely referral for VADs, transplant, palliative, and palliative inotropes. Class 1 indication, level of evidence that they do so much better if we're not sitting on them, so to speak. Remember the I need help. And so before we actually get there, some of these patients are not walkie-talkie. They actually come in, they get their big MI, and they're just not able to get out of the hospital. So what can we do for them? That's where the temporary mechanical circulatory support comes into play. So how do we identify patients with cardiogenic shock? So clinically, they come in, their systolics are less than 90 for 30 minutes. We're needing to start them on pressors. These are patients who are obviously coming in with cardiac symptoms or cardiac complications, because this can also apply for sepsis. The other thing, especially if you know there's a patient who's had decreased EF, their EF is 20%, they're coming in now, they're hypotensive, They're not themselves. They're acutely encephalopathic. We're doing RCT heads and it's negative. They're cold. They're clammy. They're not making urine. And then you check their lactate and it's elevated. Then they're probably in cardiogenic shock. Number one indication, we need to initiate inotropic support for these patients. And again, these are patients who are coming in with cardiac symptoms. And putting in a SWAN carries a 2B recommendation. And before it made it to the guidelines, sepsis protocols had indicated that PA catheters were not useful, but the ESCAPE trial went through patients who actually had cardiac comorbidities. And by that, I mean heart failure in addition to the sepsis. And they saw that patients who had management that was PA guided, PA catheter guided, did a lot better. So that's how considering of PA line placement got a 2B indication. And that's where we get the rest of the hemodynamics. Because a patient comes in, they're wet, they're not thinking well, and you're like, I'll put them on a Bumex strip. But then the creatinine goes from 1.3 to 4, and they're not making urine. And then you start wondering what is going on. You're not decongesting them as you should. You initiate inotropic support, and yes, you could have some improvement when they have a more forward flow once you initiate inotropes, but you gotta guide it. So what's the definition using PA catheter? So you have cardiac index of less than 2.2 and a pulmonary wedge pressure of greater than 15. And yes, they might have systolics that are above 90, but if their MAP is less than 60, because these patients will tend to have a very narrow pulse pressure because everything is clamping down to try to maintain that perfusion and organ perfusion. So some of these patients truly don't have hypotension, but they have the rest of they're congested, they're altered, their indexes are low, and then there are other parameters that we look into, like cardiac power output, which is a calculation of the hemodynamics that we get. And so despite improving hemodynamic compromise and they're on inotropes, and you start thinking, what else can I help this patient with? So this is the road. So it's designed to solve basically inadequate cardiac output. It's usually a bridge to recovery. So it, for patients who come in with STEMIs, they put in impellers and then they revascularize, and that can allow the myocardium to rest and then be able to perfuse better once the coronaries are open. It could be a bridge to heart transplant, a bridge to decision. So the patient comes in crashing and burning, you put it in, and you try to figure out what works best for them. Could be a bridge to bridge. We put in a balloon pump. It's not enough. We've got to go to an impeller, maybe an impeller CP, which has, and we'll look at it later, it has less flow, then we move it up, and then we move it up. So it could be a bridge to bridge, destination therapy, that's for LVADs, and for palliation, end of life care, and hospice. They're divided into left and right ventricular support. So you have the intra-aortic balloon pump, the impeller family, because it's not just the CP. There's impeller 5.5, which is surgically implanted. There's the R-sided impeller, which supports the right ventricle. There's a tandem heart and the VA. We're going to look at each of them individually. So how do we determine who needs what? Basically, the sicker the patient, the lower the EF, the lower the cardiac index, the more flow they will need. This is mainly determined by the interventional cardiologist in combination with the advanced heart failure specialist to know what the patient will need. And it's never a permanent decision because as we'll go through each of them, they each have their own complications. And before we make that final decision of what this patient needs, if they don't recover, then we would need to be switching things around. So basically, the intra-aortic balloon pump has the least cannula size. It's the easiest and the fastest to put in. We place them here at Filance all the time, and we take care of these patients in the ICU. And they use an 8 French size, but that only gives a maximum flow of 1 liter per minute. Our normal cardiac output is 5 liters per minute. So if our hearts are not doing anything, that's not going to be enough. And so that's when we consider, do they need impeller CP, which is also can be a placed in the cath lab. But when we talk about Impella 5, Impella 5.5, these are surgically implanted. Tandem heart, same thing. Via ECMO, it can be cannulated in a heart cath setting, or in a, not necessarily in the OR setting, but it would need a perfusionist to make sure that flows are fine and there are no complications arising from the ECMO. Duration of support. So these usually buy us enough time for the next thing. So balloon pump, we're only talking about hours to 1 to 2 days. Impellers, we're talking about 2 weeks max. And then tandem heart via ECMO, they can give us more time to think about. And that's, when patients would have COVID and they would have bad lungs, bad hearts, they would be on ECMO for 2-4 weeks at a time. But after that, we need to determine what else, because there's a reason why they're called temporary. Then because at some point the risks outweigh the benefits. So an intra-aortic balloon pump, what does it do? So it's basically a balloon. It inflates during diastole. So it inflates during diastole and deflates during systole. So it allows blood to flow to the rest of the organs when the heart pumps, and when the heart relaxes, it inflates, and this improves coronary perfusion. It reduces afterload, and it can give a mild increase in cardiac output. So it gives us up to 1 liter of flow. Surgically implanted, there's a radio opaque tip. Nowadays in bigger centers, they do them axillary. There's an axillary access, and that allows your patient to walk around. And this allows your patient to get better faster and not have them laying bed rest until the thing comes out. Common indications, cardiogenic shock, acute MI, and bridge to the next support. What to keep in mind if you're taking care of these patients is where the distal tip is. It should be positioned 2 centimeters distal to the left subclavian and above the renal arteries, because then if your kidneys start failing, it could be because it's malpositioned. It's widely available. It's very easy to throw in, very easy insertion. And this shows the augmentation in the diastolic phase. And so we need these patients to be in sinus rhythm, because arrhythmias can limit it, because it wouldn't be able to augment if you don't have a stable rhythm. If you have severe aortic regurgitation, it's contraindicated because it could worsen the AI. Also, if you have aortic dissection, obviously that's a no-no because it's going to propagate. If you have severe peripheral arterial disease, it's a contraindication. However, you can still put it in axillary with an axillary access. Impella devices, so we have a huge family and it keeps growing. They're easy to implant. It's basically a catheter, or they're easily to place. It's a catheter through the groin. It's a pigtail catheter. It goes all the way into the left ventricle, and it's easy to put in when you have cardiogenic shock, high risk PCI. Sometimes they'll put them in when they're doing left main disease stenting, where things could shut down and the patient could crash pretty quickly, and then they usually take it out after that. And they're percutaneous microaxial flow pumps. So basically, they suck out blood from the left ventricle, and there's an outlet above the aorta, and that's what supplies the rest of the body. There's direct LV unloading. So if you have a patient who has like a lot of congestion and they have a very dilated left atrium, this does a lot to allow coronary circulation for the LV and faster recovery. It is inserted retrograde across the aortic valve, so there's a high risk of injuring the aortic valve with malpositions. So it does improve cardiac output, and the numbers actually correlate with the amount of flow. So 2.5 gives you 2.5 liters, 5 gives you 5.5, same thing. It decreases my myocardial oxygen demand when it's offloaded. However, it comes with its complications. So if you're taking care of a patient and you're looking at their urine bag and it's turning red, they're hemolyzing. So what we typically do is take a probe on the chest and see, is it malpositioned? Is red blood cells, is there a lot of turbulence, which means a lot of red blood cells are being sheared? It can also cause limb ischemia if you're using a very high French catheter, which is obstructing flow to the distal limb. Vascular injury, obviously, you can cause dissection in the axis. The device could migrate, and aortic valve injury, which we've talked about. tandem heart. It has similar cannulation to ECMO, which we'll talk about later, but basically they put in a cannula in the venous system and it goes all the way to the right atrium and crosses over into the left atrium. So basically we are venting the left side that's not working. We're sending it to the pump, oxygenating it, and then we're sending it back to through the aortic side of things in order to perfuse the rest of the body. So blood is returned to the femoral artery. So it provides higher blood flow than a balloon pump and some of the impellers, and it's good for LV unloading. It does require transeptal puncture, which is a high risk procedure. You could have clots introduced. Patients are at risk of stroke. It's more invasive. You need the expertise for this. ECMO, we know it's extracorporeal membrane oxygenation. For our advanced heart failure patients, what they would need is VA ECMO, meaning you can provide both cardiac and respiratory support. What we do is we drain from the femoral vein, and we have an oxygenator, and then you have arterial return. So when is this done? This is done when you don't have an Impella 5.5 available and you can easily cannulate for ECMO, when you have cardiac arrest and you're still trying to figure out why did this person arrest. And now there are actually arrest protocols that incorporate ECMO. When you have fulminant myocarditis, the 18-year-old who gets the flu and you're still trying to figure things out and their lungs are bad and now they have myocarditis from the flu as well, the VA ECMO is applicable. When you have severe biventricular failure, because you can have both sides supported. VV ECMO can be used when you have a normal heart. So that's what is used mainly in the pulmonary side of things. You have rapid circulatory stabilization, which is an advantage. But the challenges is that you are putting blood back in the femoral artery. So this causes a lot of afterload. And so this increases my myocardial oxygen demand for this already failing heart. And so you have to have a plan for the heart after ECMO is done. But now they're actually combining impellers and ECMOs to vent the heart in order to prevent distension, clot formation. And there's this new termed ECPella that people will use when they're cannulating for ECMO. And there's also risk of pulmonary edema because you just have blood that's pooling in the left ventricle that can actually flow back into the pulmonary system. Some of the ECMO complications, bleeding, you're using very huge access hoses is what I call them. But yeah, you're using high French catheters. You could have a stroke because there's a lot of stasis in the left ventricle. And if that left ventricle decides to wake up, then clots can actually be sent anywhere. You can have limb ischemia because of that, infection, just because we always go groin. Hemolysis, same thing. And there's this interesting complication known as the north-south syndrome or Harlequin syndrome. It's basically you have good oxygenated blood in the peripheries, but in the brain and in the upper extremities, you have deoxygenated blood. And this typically happens when you do not have functioning lungs and some deoxygenated blood is flowing back to the sick heart. And then once it starts recovering, some of this deoxygenated blood starts perfusing these areas. And so they have to use different pulse oxes to detect this. And you can go in and find that your patient is blue on top and red in the bottom. It's very easy to identify. And they usually now will add a different cannula and it becomes VAV ECMO, which is a little complicated, but perfusionists usually know what they're doing. Right ventricular assist devices, we see this required a lot in patients who have RV infarcts. So patients who thrombose their RCAs. And we can also see this in patients who have had durable LVADs, that they might have failing rights because the LVADs are LVADs, they're not RVADs. And so the right is left own devices, so to speak, and it does tend to fail over time. Impella RP is an option. tandem RVAD, where you're putting in now a cannula from, it's sucking in from the right atrium and pushing blood to the pulmonary artery. So bypassing the sick RV, helping it recover. Protect Duo is same concept, but it's you basically cannulating the neck vessels, and then VA ECMO. So VA ECMO can be a solution to everything when you have this globular heart where nothing is working, the right is not working and the left is not working. So those are temporary MCSs. So what are some of we've gone through some of the complications and limitations, but there are contraindications to some of these. So severe peripheral vascular disease, usually when you have bad PED in the legs, you'll have bad PED everywhere. If you have abdominal aneurysms, you shouldn't be putting in or shouldn't be sending your patients in for balloon pumps. But the biggest thing is if you have any contraindication to anticoagulation, because these are, they're basically foreign bodies. And so you need to put them on anticoagulation, heparin drips, bivalirudin drips. And if you have any contraindication, then we start talking of palliative if they cannot have temporary MCS, because also a durable LVAD is a foreign body and they need to have therapeutic anticoagulation moving forward. So that's a huge one to think about. So left ventricular assist devices. We have first generation, second generation, and now we have the hottest VAD in town, which is a HeartMate 3. Anyone who's getting an LVAD today is getting HeartMate 3 LVAD. And the reason why is initially people thought we'll create a mechanical heart and it'll work exactly like the native heart. So initial technology was pulsatile, but they realized that all this mechanical movement is bad for the blood itself because there was a lot of hemolysis, poor durability, because this thing is moving all the time. So you needed to charge it all the time and parts would break down. Patients would be dead in a year. So then more research was done and they came up with the HeartMate 2, which is the second generation. So it was smaller and it was more, it was outside the pericardium, but much smaller than the first generation. And there were bearings, so there would still be, and blood would come into contact with the pump. And so there would still be a lot of hemocompatibility issues like thrombosis and factors, clotting factors would be affected because of this sheer forces that were going through when the blood was going through the pump. And so they came up with the third generation. It's smaller, it's intrapericardium, has a long battery life. You still have some of these complications like thrombosis, stroke, and GI bleeds, but a lot less. And yes, more research is being done to improve this technology. But HeartMate 3, the biggest thing for it is that since there was a lot better compatibility inside the pump itself, there was less pump thrombosis. Pump thrombosis essentially means you take the entire thing out and you put it back in. No surgeon wants to do that. And so that's why it became very popular. And so these are the components. So you actually, the intrapericardial pump itself, they core out the apex and they suture the pump onto the apex of the heart. And then there's a driveline that comes out. And the driveline connects to the system controller. And this is basically the brain of the pump. It is powered with two batteries that together have up to 17 hours of uninterrupted power. And then you have a drive line, which is the externalized portion of the pump. So basically, these patients have a little hole coming out of their bellies that has to be dressed sterilely every so often. And they get instructions. And this is where caregivers come into play because they determine a lot of how clean this is kept and infections mainly coming through the driveline. Part of our wish list as advanced heart failure docs is that we'll get rid of this driveline entirely. But until we get there, we still have to deal with this. How do LVADs work? So basically, it's a pump at the end of the day. It's preload dependent and it's afterload sensitive. What does that mean? It needs blood to pump. And if there's a lot of pressure where it's pumping, it's not going to pump well. So preload, we think of, how much blood is in the system, how well hydrated are we? So if we're bleeding, if we're anemic, if we're dehydrated, the pump will not basically pump how much we want it to do. And this is the console for the HeartMate 3, and this is the controller. But we, as physicians, can only set the LVAD speed. And then the LVAD speed will control the pump flow, the pulsatility index, and the pump power is basically how much power comes from the pump itself. If we're trying to adjust any one of these and we run into problems, is when we start troubleshooting. So, for example, if our flow is low and our pulsatility index is high, we try to think, is there enough blood in the system? That's when we start thinking of arrhythmias. Is the RV failing? If the RV fails, it balloons out and there's more blood on that side. And so we have to try to think of more ways to help the RV. Are we doing afterload reduction in the lungs? Are we giving like sildenafil to help things flow? Are we diuresing enough? Is there bad TR that needs to be fixed? Arrhythmias are a big thing too, which affects the preload, and also overdiuresis. If you have your patients who are on Bumex and we're not getting rid of it and their kidney function is going up, we need to think of stopping it. Afterload is basically affected by the blood pressure. And the blood pressure in this case for LVAD patients, we and I'll talk about it hopefully in the next slide, but we look at the mean arterial pressures. Remember, these are continuous flow VADs, so patients do not have pulses. It's not palpable, and usually this is a big thing when it comes to ACLS, which we'll talk about later. So your blood pressure cuff may not be accurate and your pulse ox may not be accurate. Sometimes if patients have a aortic valve that's opening and closing with every beat, you might have a systolic and a diastolic, but that's not always reliable. So we usually measure with Doppler devices where you measure the mean arterial pressure. So you occlude the cuff and then you start deflating it until you hear a standard hum, and that's the actual blood pressure for this patient. So we do have Dopplers, when we're assessing blood pressure, when we're assessing PAD in patients, sorry. And so if we ever come across an LVAD patient, this is something to consider if they're not doing well. But keep in mind, we're thinking of the advanced heart failure patient. So if we're talking to them about sending them for getting a VAD, they can never swim. Again, it should never be submerged in water. There's a potential active site. Basically, think of this drive line going from the skin to the heart. So it's a direct connection. So and infections are a nightmare. So these patients can never swim. They can never have contact sports or strenuous exercises. So that's something to talk to them about if they're ever considering this. Diagnostic MRI is also contraindicated. So if we ever need to figure out other things, and CT is CT and PET scan are modalities. Sometimes we'll need to figure out, are they having infection or, what's going on with this valve. So other modalities will need to be used, but not MRI. This is just a graph to show in the beginning, the blue indicates continuous flow VADs that were axial, so HeartMate 2s. And that number has gone down. So there was a hybrid LVAD called a Heartware that kind of came in and fell out of favor. And the green here is indicating the HeartMate 3 pump. So a lot of patients now that we'll come across will have the HeartMate 3 pumps, but there's still some people living with the older VADs. So it's the treatment option is important because donor hearts have not increased. The donor pool still remains limited. We're looking at xenografts, we're looking at pigs because the number hasn't increased. I mean, yes, the transplant number has increased, but very modestly. So this is a viable option. And why is it a viable option? Because of this huge unmet need for. Reason why we're talking about this is to know that there is an option, because it still can add years to the lives of patients, and it can also add life to their years. And we'll see how good these patients feel once they get their VADs. In 2022, here were the statistics that were there at that time. There were 27,000 patients living with LVADs and only 4,000 patients living with transplants. So these patients who are LVAD patients some of them are bridged to transplant patients. And so they're having to lead better lives than they were with advanced heart failure, because a lot of patients die on the transplant list. What are the indications? So it's some of it is I need help, but if we're inotrope dependent, we cannot get out of the hospital. We've weaned down the mechanical support, but they need like some dobutamine to go home with. These are bad patients. If their end organ dysfunction is because of their bad heart failure, then yes, these are indications for LVADs. But something we don't talk about is what are the contraindications. Absolute contraindications: if they have irreversible cirrhosis, if they're almost on dialysis, if they have devastating strokes, if they cannot adhere to medications or follow ups, then these might not be your candidates. If they're loners, if they don't have anybody to take them for these appointments, because part of the evaluation for these patients is who's going to address their drive line, who's going to call the LVAD coordinator when they're down. So, and that sometimes I'll see my patients and I'll be like, hey, think about that sister of yours who lives the next city over, because you might need them more if I send you for these therapies. Relative indications is age. So for transplant cutoff is 70. For VADs, I mean, Dick Cheney had his VAD at a very old age. So greater than 80 for destination therapy. Obesity, so this is where our GLPs come in. We have our patients with BMIs of 50, 60. If they get on their GLPs or get their bariatric surgery, they can still have indications for VAD once that's improved. Same for malnutrition, if we correct that. Untreated malignancy, if it's not metastatic, it's an indication. For malignancy, it's a contraindication for transplant because immunosuppressants will bring out will feed the malignancy, so to speak. Active substance abuse, if you can get the patients to change their ways, and lack of social support too. If that situation can change, then they should be indicated. So it needs a big team. Whenever we send these patients, we talk of the heart team, which is the doctors, the surgeons, the LVAD coordinators, pharmacists, nutritionists, psychologists, social work. These are all these people talk when they're talking about a patient and their candidacy. So it's not just one person deciding. And so there are a lot of cracks that are caught when we're evaluating these patients. So just to plug in again, the HeartMate 3, the 2-year story. So they looked at 2-year and 5-year outcomes. So there was 80% survival at 2 years. They were doing really well in terms of their quality of life, and the adverse event profile was so much better. There's evidence to show that earlier implants too would lead to higher survival. So patients who are NYHA4, not necessarily in the hospital, but just not doing well, the I need help people. KCCQ score, so it's a Kansas City cardiomyopathy questionnaire score, is like, what does improving the quality of life, what does that really mean? So patients are able to walk 1 block or more, 71% of VAD recipients. ADLs are taken care of, significant decongestion, and significant increase in satisfaction living with their heart failure diagnosis. And now the 5-year story, which was very recent, nearly 60% of these patients are still alive. Some of these patients were transplanted, and their quality of life continues to go up. And so they are not the perfect solution because LVAD complications do arise, and we've kind of touched on these before. So hemocompatibility adverse effects, and these include pump thrombosis, stroke, or bleeding. Early on, these are the ones that we come across. And then later on, we are talking about the right heart because it's not supported. And sometimes if the VAD speeds are not optimized, then the septal portion that helps LV output, cardiac output from the right side, is affected. Aortic insufficiency, with time, with this valve not opening and closing, the valve sclerose over time, and the valve itself fails. So you find a lot of patients needing valve replacements like TAVRs patients with that, or they just go straight to heart transplantation. And going from top to bottom, strokes for patients who have high MAPs that are untreated. We've talked about aortic insufficiency. Pump thrombosis is huge. There's a 1.1 to 12% incidence. If the patients are not taking their anticoagulation, if they're having issues with the pump itself, sometimes they can get by increasing their anticoagulation, but if it's affecting the pump such that you have starts and stops, this can essentially kill a patient. So they need pump replacement. Driveline infections are huge, usually happen in younger patients because they're more active, and also patients with poor hygiene, patients who don't have much support. The support was there at the beginning and then it kind of trails off. Typically, antibiotics can cover, debridement can cover, but if it gets to the pump itself, it might need replacement, which is, again, increased morbidity and mortality. Gastrointestinal bleeding. So being pulseless, a lot of these patients form AV malformations, and a lot of them happen in the GI tract and in the small intestine. So they get their EGD, the colonoscopy, you can't find the source of bleeding. And, you call in your GI, usually they'll try octreotide for this. And sometimes it becomes a little bit of an issue. They might have to do a push enteroscopy to get there. And if they can't, you bite the bullet and you stop the anticoagulation. And some people do fine, but that's when you start bringing in Dr. Robinson and his team, talking about the fact that we can either go to a transplant or palliative care, because at the end of the day, VADs do not give you a full life, but they can add up to 10 years to your life. And this is somebody who would have been dead in 2 years. So we're talking about increasing years to their life and life to their years. But yes, it wouldn't be fair not to talk about the complications whenever you're thinking of sending these patients to the next level. And now a lot of these patients are in our community, and they do end up having cardiac arrest. And so they're coming up with algorithms. Different places have different algorithms. So, but a common thing to figure out once a patient is unconscious is the pump on? It might just be as simple as this thing needs battery. But you also look at perfusion. You look at them clinical. Are they cold? What's the pulse ox? It's different from, do they have a pulse? Because you might not feel their pulse. They always have their coordinator's number, so they are always called. But if they have a shockable rhythm, shock them according to ACLS guidelines. Prior, there was the notion that if you do chest compressions, you will dislodge the pump, but that's not the case anymore. You do ACLS, or you as you would typically. And then if there's a Doppler map available, you check the maps if you achieve ROSC, so to speak. But yes, chest compressions, if VAD patients go down, make sure the pump is on, call the VAD coordinator. And so basic takeaway is that we need to identify our advanced patients early. We need to find this golden window of referral. So when they have NYHA 3 to 4 symptoms, their GDMT is not being tolerated, frequent hospitalizations, their end organs are not doing well, we don't want to find them when they have multi-organ failure and they're basically cannot be helped. And so we need to recognize, educate the patients, everything we've talked about today, including the good stuff and the bad stuff, identifying who's a candidate, who has family support, who's motivated, who can do the trek. Sometimes, we're talking about commitments of every month or every couple of weeks going to bigger centers, and then co-managing them. So some of these patients do come back. We get to see them. We get to because even patients on VAD still need their GDMT until they get a heart, and then you don't need that anymore. So we can do this for our patients. So key takeaways, let's recognize them early. Let's remember that they're temporizing mechanical support to lead to the durable VADs, which are long-term solutions now because transplants are not available. And then early referral is key to optimal outcomes. Thank you. Sure.
What is the approach that they will advance to a heart transplant or not necessarily? Is the approach of the provider to say, this is just where we're going to go and transplants kind of like now on a back burner, or what's the mentality?
So that's an excellent question. So every time you're considering an advanced heart failure patients, LVADs have bridge to transplant indications and bridge to destination, or destination LVADs is what we call it. Obviously, if this patient is greater than 70 years old, it most likely will be a destination LVAD. If you have younger patients, 18 to 69, or even 70, some good 70-year-olds, like 70 as a cutoff, they are always considered for transplant. And then as the committee meets, they say, yeah, we can do transplant because they have active prostate cancer, or they have this reason or that reason. Yeah, so they're always considered for transplant pre-70.
Is like UH, or is it specialized, tertiary care centers that are doing the LVADs?
It's specialized tertiary care centers. So UH is doing them, University of Toledo, I believe, Cleveland Clinic. I'm not sure if ProMedica is doing it, but yes, tertiary centers. All right. Any other questions? All right. I hope we learned something today. So recognize it in your patients, family members, because there's a lot that can be done for these heart failure patients, especially those who get admitted frequently. All right.